Well, welcome. On behalf of myself and Stephanie Berg, we would like to welcome you to the 25th annual meeting of the KCA International Kidney Cancer Symposium in North America.
These aren't the slides that we had. Maybe the next slide. Oh, good morning, everyone. As Jody said, thank you again for attending our 25th annual IKCS meeting. Again, our theme for this conference is Bridges to Cure, Innovating Kidney Cancer Care.
So the planning committee started in the spring and put together this fabulous agenda and scientific program that you're about to watch. And we are eternally grateful to the faculty who agreed to come and speak and make this meeting. And to our planning committee, pictured here, thank you all.
Some of our program highlights include, as before, we had over 58 abstracts. We have some sessions that were highlighting of the women in RCC. We had our young investigator session this morning, and of course our wood fire session tomorrow afternoon. Really highlighting our keynote speaker, Dr. Celeste Simon, later today with her topic, Targeting Metabolism, Beating Kidney Cancer at Its Own Game.
And please, when you see them, congratulate this year's award winners. David Braun is the winner of the Chris Wood Award, Rising Star Award, Naomi Haas for the Eugene Schoenfeld Award, and Dan George for the Nick Vogelsang Humanitarian Award.
This is a little bit of a delay. It's a little delayed.
Can you help us advance
There
the
we go.
slide? All right.
And we want to thank our sponsors and media partners listed here. Without this, this meeting is very, very important to our meeting, and we welcome interactions with everybody and look forward to a great few sessions in the next 2 days.
We might need a new battery.
Yeah, it's not really working. Yes, it doesn't work, yeah. Oh, that one's better. And remember that we're offering CME for our meeting. The activity is available for 13.25 credits. Please fill out evaluations at the end of the program to receive credits, and any speaker disclosures can be found in the meeting app. So we're actually gonna get started right away with our first session. I'm gonna start with Jody here to talk and present a case.
Yeah, so this session, we sort of envisioned it as a what to do when you can't operate session. And as you can imagine, that sort of has two different poles. The first being the tumor that's inoperable, and the second being a patient who may be perfectly operable, but not a candidate for anesthesia, simply not a candidate for surgery. So we each brought a case. Here are the learning objectives for this. I'll let you look at those in the program. Oh, first, let me introduce our distinguished panel, and you can help me out here, Stephanie. On your far right is Dr. Leonard Appelman. He's a medical oncologist from the University of Pittsburgh, and well known to me, he's my husband. The next is Dr. Stephen Chang, who is a surgeon, an excellent surgeon from Brigham and Women's Hospital and Harvard University. And then our third speaker is Dr. Rakik Hanan, and forgive me if I've mispronounced that, a radiation oncologist from UT Southwest. So this is a case that Len actually sent to me. He's a 66-year-old guy who is on 4 liters of oxygen all the time at home. He has kidney disease. He has CAD and new onset atrial fibrillation with a recent TIA. And he has aortic stenosis. He just got out of the hospital where he was admitted for 3 weeks with pneumonia. And when he comes into the office, he immediately fails the eyeball test. He's frail, he's in a wheelchair. When you chat with him, he says that he spends half of every day in bed, even before he got the pneumonia. This tumor that we're looking at is a partially cystic, very exophytic tumor. And 2 years ago, or 18 months ago, it was a centimeter smaller. It's clearly growing, it's clearly enhancing. And as a surgeon, that's a really tasty tumor. If I hadn't seen the patient, I would have said, let's go. It would be very amenable to a partial nephrectomy, but this is a gentleman who would never get cleared for anesthesia and has a high likelihood of not surviving and general anesthesia. And Stephanie, your case?
So this is my case, as I was the attending on our ONC-F service at Brigham Women's. So Jane is a 61-year-old woman. She first presented with intermittent abdominal pain, nausea, and vomiting for the past month. No hematuria. She has chronic systolic heart failure, class 3 obesity, BMI of 45, obstructive sleep apnea, chronic kidney disease, hypertension, and diabetes. So they came in, she was a transfer from Maine. We get these a lot for second opinions. These are her MRIs, and I called Dr. Chang at the urology service. What can we do? So these are some pictures from her abdominal MRI and CT, so we can see here a large right-sided mass invading into the IVC. But as the medical oncologist, I said, well, it could be, kidney cancer or lymphoma. But, of course, we had to get a biopsy, and it did actually confirm clear cell kidney cancer. So Furman, grade 3 of 4, positive CA9. So now those are just for a little bit of context of what we can do. We'll talk about the cases afterwards, but first I'm going to introduce Dr. Chang to come up and start off our session.
Good morning. Thank you very much. When I was asked to talk about this inoperable kidney cancer, I'm like, what's inoperable? I'm a surgeon. I can't really say that, right? But I was asked or tasked to speak about some background on renal cell carcinoma with IVC involvement. We're talking about the epidemiology, classification of these tumors, as well as predictors of good and poor outcome, as well as a few take-home messages. So among the roughly 81,000 expected new cases this year of renal cell carcinoma, 20% of them roughly are these more locally advanced cases. Among those, a small proportion have extension to the IVC, and a relatively rare case has extension into the right atrium. These patients potentially who undergo surgery can potentially do quite well if all the disease is resected. Conversely, those who do not get treatment with surgery do uniformly poorly. A poor outcome, 1-year disease-free survival, disease-specific survival of 29%. In terms of classification, I think we're all familiar with the TNM classification system, and we're really here focused on the T3 disease. T3A, renal vein or segmental branch involvement, T3B, IVC involvement below the diaphragm, or T3C, above the diaphragm, or involvement of the IVC wall. And these three stages have been associated with worsening median survival. A, B, and C are associated with worse median survival as you go up. But from a surgical standpoint, our focus is heavily centered on the anatomy and where the tumor is with relationship to critical anatomical landmarks. Arguably, the most common classification system for this is the Mayo Clinic classification. Level 0 is disease solely within the renal vein. Level 1, into the IVC, but within 2 centimeters of the renal vein. Level 2, above 2 centimeters, but below the hepatic veins. Level 3, at or above the main hepatic veins, but below the diaphragm. And level 4, above the diaphragm. While the system is critical for surgeons, in terms of knowing how to approach a surgery, there hasn't been a great distinction between the outcomes, except if it's in the renal vein, it's better than any of the other levels. But from a surgical standpoint, it is critical because as the level goes up, the surgical complication similarly goes up. And it also dictates how we approach this. Level 0 and 1 is basically a urologist surgery. Whereas 2, 3, and 4, this is involving multiple teams, a urologist and a hepatobiliary surgeon or vascular surgeon for level 2, and 3 and 4 often involving cardiac surgery as well, as there may be a role for cardiopulmonary bypass. But what are predictors of good outcome? I wanted to highlight a couple studies done by 2 different institutions at UT Southwestern, this paper looked at before and after a dedicated multidisciplinary team was established. And you can see there's a clear advantage to a dedicated multidisciplinary team approach. Reduction in complications, specifically reduction in high grade, meaning Clavian 3 to 5 complications. At Emory, a similar effort was made, and you can see across the board, OR time, need for ICU stay, length of stay in the ICU, blood loss, 90-day mortality were all improved with this multi-specialty approach. And with all things surgical, you would think volume is helpful. And sure enough, surgeon volume and hospital volume has been looked at with regards to outcomes for patients with IVC thrombus. And it seems like surgeon volume is the more compelling of the two. Surgeon experience, particularly in the early few cases, is really where the greatest degree of morbidity and mortality lie. But of course, outcomes are associated with age and comorbidity status, and certainly the need for a cardiopulmonary bypass. And I think that that's a good segue to really the obvious point which Jody brought up earlier. It's really the health of our patients. If we have someone who looks like this, they will do well no matter what. Unfortunately, most of my patients look more like this: the obese, the elderly, and the people who make bad decisions. And really, it's about the physiological reserves. So it's hard to quantify this, but usually you can just sort of eyeball a patient and say, this may not be such a good idea. Certainly the points that Jody brought up earlier about being on oxygen, being in bed most of the day. But what more objective data do we have? So sarcopenia has been really identified as a poor predictor of many situations. This is loss of skeletal muscle mass, strength, function, and it does lead to a whole host of poor quality of life aspects. But specifically with patients who undergo a cable thrombectomy, there is clear detriment in outcome when one has evidence of sarcopenia. Systemic inflammation, and this is neutrophil to lymphocyte ratio, the NLR. If it's greater than or equal to 2.9, this has been shown to be associated with poor outcomes. And a similar evaluation with the systemic inflammatory response index, adding monocyte count really to that calculation. Greater than or equal to 0.81 has been associated with poor outcomes following a cable thrombectomy. And I want to highlight another situation of Budd-Chiari syndrome. This is classically identified as a situation in which patients really should be concerned about whether or not they should undergo the surgery. Patients who had this obstruction of the hepatic veins, evidence of hepatic organ dysfunction, these patients have an extraordinarily high mortality following radical nephrectomy with cable thrombectomy. But there are some other identifying features on imaging, really. IVC wall invasion, and this is clearly associated with larger tumors and higher level thrombus. These patients really require a much more surgically complex approach. Some patients, just simply a patch is necessary. Other ones require a complete replacement of the IVC or a large portion of it. And those patients have greater OR time and blood loss, major complications, and mortality as well. And then if tumors seem to grow in an abnormal fashion, so typically we would expect tumors to grow sort of the direction of the venous blood flow. However, you start seeing tumors that are moving in a direction such as in this case down the gonadal or up the left adrenal, then these patients seem to have a worse outcome as well. So finally, the take-home messages are really that this is a relatively uncommon situation, but associated with a high surgical morbidity and mortality. That the level of the thrombus dictates a surgical approach, and a multi-specialty care strategy is really the one that's been associated with better outcomes. And finally, poor outcomes are something I would be very concerned about. The poor health of patients is a major dictating factor here, but certainly IVC wall invasion and an unusual growth pattern of tumors is poor characteristics associated with this disease. Thank you very much.
Okay, Dr. Hanan.
Good morning. and thank you for inviting me to talk about stereotactic radiation, or SABR, for locally advanced unresectable primary kidney cancers. I don't know if it is advancing. Okay, so the learning objectives, we will talk about stereotactic radiation, or SABR, for the treatment of inoperable, primarily inoperable RCC, where majority of the data lies. And then we'll go over some cases and the limited data there is for cytoreduction, consolidation, and palliative radiation. So brief introduction to what stereotactic radiation is. We call it SABR, or SBRT. It is high focally ablative dose that we can deliver using advanced technology to tumors located anywhere in the body, conveniently in 1 to 5 fractions or 5 treatments typically. It is completely non-invasive, and data has shown that for both primary and metastatic treatment, stereotactic radiation has high efficacy and safety ratings for kidney cancer. So here's the data for primary renal, and these are mainly inoperable patients. From the IROC consortium, multi-institutional consortium, we submitted cases and a total reviewed 190 cases, a median follow-up of 5 years, and a median tumor size of about 4 centimeters. We reported a local control rate of 94%. Grade 3 toxicity was none. There was one patient that experienced grade 4 duodenal ulcer. There was some decline in EGFR, about 14 mLs. And interestingly, single treatment radiation actually performed better. This is one of the first phase 2 studies that we have reported with a small number of patients, 16 patients, but all biopsy confirmed RCC, and then we also confirmed pathologically local control at 1 year. But with a median follow-up of 3 years, our overall local control was 94%. Peter Mack soon reported phase 2 study. This is one of the first multi-center phase 2 studies. They enrolled 70 patients, and they treated with single fraction or 3 fraction radiation, 43 months of median follow-up, and a median tumor diameter of 4.6 centimeters. They reported a local control rate of 100%. Their toxicity was, grade 3 toxicity was about 10%, which I think correlates with a little bit higher radiation dose that they have used. The EGFR decline was similar, about 14 to 15 mLs. So going to even larger tumors, the data is limited at this time, and this is another IROC consortium study that looked at only treating grade T1B or higher tumors. So median tumor diameter was 4.9 centimeters. And at 4 years, the local control rate held at 97% with no grade 3 or 4 toxicity. So in terms of inoperable tumors, these are the retrospective and prospective data. So now let's talk about even larger tumors. So for the purpose of cytoreduction, there really isn't much data, but I'll give you one case. Actually, a number of cases that we have treated. This is one of the cases of a 57-year-old lady who presented with this primary kidney tumor and lung metastasis, started on EP-Nivo and had control in the lung, but the primary continued to grow, and she developed multiple hospitalizations for hematuria, and blood clots. So we planned her for consolidation as well as palliation and cytoreduction. We started with planning the full 40 gray in 5 treatments. You can see why this would be challenging, because you have the duodenum and all the bowels right around it, and this clearly, of course, has local invasion into the liver. So we used a newer approach called Pulsar, which is really adaptive SABR. So what it is doing is it's giving one treatment, waiting for a month for the tumor to respond to that big treatment dose, and then replanning again. So with each monthly treatments, you can see how this tumor continued to shrink, and with that, we continued to shrink our radiation fields, and thereby able to spare more bowels and actually successfully able to deliver the 40 gray. So upfront, if we try to deliver the 40 gray, we will never be able to do it without toxicity. But this patient tolerated it very well because we kept shrinking our fields, and eventually we were able to deliver a very high ablative dose. And now it is about 8 months follow-up, and the patient is locally controlled as well as systemically controlled. The primary continues to shrink. In terms of cytoreduction, there is 2 trials that are ongoing that we are eagerly waiting the results. Samurai is enrolling, CytoShrink has completed enrollment, And these are both in the setting of IO, combining cytoreduction of the primary inoperable tumors. And we will see how the results pan out. So what about palliation? So the palliative data for RCC is actually even more scarce, and I could find a case report of primary where another patient that was presenting with hematuria, anemia, and surgery was not possible because the patient was just not in good shape for surgery. Angiography and embolization failed to control the bleeding, and they did 35 gray in 5, and the hematuria completely resolved in 3 months. There is another small prospective study out of Canada for palliative radiation that I did not bring in because they also included metastasis, and they showed similar controls, but instead we started looking at our own database, and this is yet unpublished, but we identified 240 RCC patients, both primary and metastatic, where we gave radiation to 581 sites, and inclusion criteria for this study was patient had to have any sort of symptoms. So majority was pain, but you can see that there was others as well, including bleeding. And overall improvement in symptom was 86%, and the median time to resolution of the symptoms was 1.7 months. And interestingly, SABR and conventional radiation did not have a difference in terms of symptom palliation. SABR clearly is preferred for local control and consolidation, but for palliation, you may be okay just doing conventional radiation. So I'll finish with some cases for IVC tumor thrombus where the data is also much less. We started with a case report that we published several years ago of a level 4 IVC tumor thrombus that we radiated with high-dose radiation. This was 9 gray times 5 in each treatment. You can see that this thrombus is going into the right atrium. And over a period of 1 year, there was significant shrinkage of the tumor volume and the diameter of the IVC thrombus, as you can see in the panel E. We went around, and because these cases were so rare, multiple institutions submitted cases, and we were able to put together a case report of 15 patients where we saw almost 60% of the time radiographically we could detect the change in IVC thrombus after stereotactic radiation, and all patients derived palliative and symptomatic benefit. Here is one of the cases of a 38-year-old lady who presented with a level 4 thrombus, and I don't think we have a laser pointer, right? No, okay. So I'll try to describe the...
It's the red button. The red button.
Oh, it is, okay. No, red button. No, I don't think we have a laser pointer. That's okay. I'll try to describe my best the case. So 38-year-old lady presented with IVC thrombus that is level 4, as you can see in the first figure A. The IVC is crossing over to the right atrium past the diaphragm, and she clearly had butt Chiari. You can see the white ascites in the second, on the top row, the second panel, with the red arrowheads that are showing the ascites. Of course, elevated LFTs, and the third panel, the white arrow is showing that the right hepatic vein is engorged, and you can see that portion of the liver is not nearly as well perfused as the other one. We consulted our surgeons, and the surgeons said clearly this is in the setting of butt Chiari, this patient will have a high rate of mortality for surgery. So we started the patient on systemic therapy as well as stereotactic radiation, as you can see in the second in B. And then 6 weeks later in panels C, in row C, you can see that the thrombus already started shrinking and showing signs of decreased enhancement. The ascites, which is in the second panel, you can see the red arrowheads, is already decreasing. And 7 months later, her LFT is completely normalized, and you can see the ascites is completely resolved, the hepatic vein engorgement reduced, and now the liver is perfusing well. So this patient then underwent radical nephrectomy and thrombectomy, and 3 years out, she's still doing well. She has metastatic disease, but still she's on systemic therapy and she's doing well. Another case that Dr. actually Cheng already alluded to, you can see on the right side, this patient has a thrombus, but there is the irregularity on MRI on the IVC wall, showing the invasion of the IVC wall. We had a multidisciplinary discussion, and it was deemed very high risk for surgery. So in a planned way, the patient underwent radical nephrectomy, not a thrombectomy, and then we treated the thrombus with stereotactic radiation, and the patient is now doing well. So we do have a neoadjuvant IVC thrombus radiation followed by surgery, a phase 2 trial that completed enrollment that I did not bring in here, and that we will read out hopefully in the next year or so. So with that, this is my take-home message. Stereotactic radiation, or SABR, is non-invasive, has high efficacy and excellent safety profile for primary RCC. For non-operable cases, SABR can offer effective palliation, but also consolidation and also local control. Future directions include integration of SABR with IVC thrombus in the neo or adjuvant setting, and cytoreductive nephrectomy in the setting of systemic therapy, particularly IO, when the trials read out. Thank you.
I'd like to thank the organizers for the opportunity to talk about medical therapy for unresectable renal cell carcinoma. Downstaging is defined as systemic therapy for a locally advanced renal tumor with the goal of converting an unresectable tumor to one where you can get negative surgical margins. This includes patients with localized disease as well as patients with metastatic disease where the goal is to allow a cytoreductive nephrectomy. There's also a population of patients who have a solitary functioning kidney or low GFR whose tumor is not amenable to nephron-sparing partial nephrectomy, and systemic therapy is used with the goal of facilitating a partial and allowing that person to remain off hemodialysis. What can we learn about downstaging from other cancer types? I'm not going to go through this whole slide, but to summarize it very, very crudely, systemic therapy for unresectable solid tumors works sometimes. That's the take-home message, and it's really based on single-arm and small randomized studies. I found that this population of unresectable cancers is really less well studied than neoadjuvant therapy for resectable tumors, where we have big randomized trials with solid endpoints like event-free and overall survival. So what about renal cell carcinoma? Shortly after the advent of the VEGF receptor TKIs, Dr. Bex and colleagues reported a study of sunitinib in patients who had surgically complex local tumors. They noted that within the community of urologic surgeons, as Dr. Chang alluded to, there's no uniformly accepted definition of unresectable tumor lesions. With sunitinib, 3 out of 10 patients were able to undergo cytoreductive nephrectomy following downstaging. They were cautious in noting that they couldn't conclude the systemic therapy was directly responsible for that. Dr. Rini published a study in 2012 in sunitinib in patients who had an unresectable primary tumor as defined by size, lymphadenopathy, venous thrombosis, or proximity to local structures. 13 out of 30 patients were able to undergo resection after sunitinib treatment, 4 radicals and 9 partials. Dr. Karam presented a study with axitinib in patients who had T2 to T3b tumors who received axitinib for 12 weeks. The objective response rate, primary endpoint, was met with 45.8% patients having a partial response. No patients had progressive disease, and 5 patients were converted down to partial nephrectomy. They were also cautious not to directly attribute the systemic therapy to that conversion. Dr. Rini published a paper studying pazopanib in patients who had a solitary kidney or a critically low GFR. And after treatment with pazopanib, there were 6 out of 13 patients for whom partial nephrectomy was thought not possible pre-treatment who ultimately underwent a partial. As to the topic you heard about, IVC thrombus, Dr. Stewart and colleagues performed a study of 24 patients who had IVC thrombus, treated with axitinib for 8 weeks. 32% had a decrease in the venous thrombus level, and 41% had a change in surgical approach. Just to summarize, the studies shown here, as well as a notable case study from Emory with cabozantinib. Now we turn to the era of immune checkpoint inhibitors. I'm going to show you a retrospective study from Dr. Panian and Dr. McKay with 9 centers contributing cases, patients who had locally advanced RCC not resectable as defined by the local providers. The primary endpoint was downstaging by T-stage. 52 patients were part of the study. 44% received an anti-PD-1, anti-CTLA-4 combination, a quarter PD-1 monotherapy, and a quarter PD-1 TKI combination therapy. Pathologic downstaging by T-stage was achieved in 44%, and remarkably, 7 patients, 13%, had no residual disease at nephrectomy, 5 clear cell cases, 1 papillary and 1 translocation RCC, 3 who received ipi-nivo, and 4 single-agent nivolumab. In the last couple of years, we've seen many additional papers come out describing immune checkpoint inhibitors, primarily in combination in this unresectable group with downstaging. And if you look at the right side of the table, you see in bold red, we're starting to see many patients with pathologic complete responses, which is really, really new for us in this field. Talking about the medically inoperable patients who have a localized tumor, potentially completely resectable with surgery, but are just too high risk medically, and who cannot undergo ablation or the elegant radiation techniques you heard about. What are our strategies? Systemic therapy is potentially an option. Surveillance, waiting until the cancer is an acute threat more than the toxicity of disease, and best supportive care may be appropriate if it fits with that patient's goals given the complexity of their medical condition. I honestly was not able to find very much in the literature. Maybe I'm missing it studying these patients, and I think it's because with all these options for local therapy coming, there are not many patients who fit this criteria. If you think about the patients who can't undergo surgery, ablation, or radiation, but who would tolerate our medical treatment and for whom the renal cell carcinoma is more of an immediate threat to them than their competing morbidities, the patients who meet all 4 of those criteria is ultimately not a very large subset of patients and difficult to study. The take-home message is unresectable RCC is not easily refined given the infinite anatomic presentations, diverse surgical options, and I'll add here the expanding innovations of our colleagues in surgery, radiation oncology, and interventional radiology is shifting the goalposts in a good way. To summarize the data very crudely, downstage systemic therapy may sometimes be helpful, and this is where you need the multidisciplinary team. And new data, emerging data, with combination therapy, we are starting to see pathologic complete responses. Finally, the medically inoperable patients with primary RCC are not well studied and require individualized collaborative care. Thank you.
Well, thanks to all of you. Excellent talks. We're going to go back to case 1. Again, this is the gentleman who's just been put on anticoagulation, is on oxygen, spends half of every day in bed, and has very poor kidney function at baseline. From our panel, what would you do for this patient? Steve? You're going to tell me just operate, right?
Yeah, no, I think that all the points that were brought up are absolutely appropriate in the sense that this is a patient, as Dr. Appelman probably just mentioned, like their competing risks of mortality are arguably higher than the risk for RCC. but we can't really ignore the RCC completely. I have been consulting our colleagues in radiation oncology more and more about these patients for SBRT or frankly SABR. Is that a possibility in this situation?
Yeah, so I cannot see, I would like to see some of the axial images to see the proximity of bowel, but from what I am seeing, there is no bowel nearby. Liver is nearby, which is really not a problem for radiation, so it should be fairly straightforward. If bowel is not nearby, I would actually even do it in single fraction, single treatment. But if bowel is nearby, then we will use either 3 or 5, and then depending on how much bowel is nearby, we may need to do adaptation, but it's clearly possible to do good local control on this.
Thank you. It's unfortunate that Dr. Schmidt couldn't join us from interventional radiology, but some might say, what about percutaneous thermal ablation? That is complicated here by the large cystic component and also by the fact that, at least at our institution, those procedures are done universally under general anesthesia, which we've already ruled out. So we did, in fact, refer this to radiation oncology. They didn't do it in 1 fraction, as you suggested, but they were able to do it without any anesthesia in 3 fractions, and with an outstanding outcome. The gentleman's still doing very well today. Stephanie?
Oh, there we go. So going back to my case, so again, this was our patient that got, I forgot to mention, she was one of those overnight transfers from Maine for really a second surgical opinion. So on the medical oncology service, working up all of her comorbidities, she actually, I forgot to say, she actually had a lot of pain. So we actually brought up many discussions with her. And Dr. Chang, do you remember what happened with this case? I think it was one of the fellows also was on it first.
I don't have the perfect memory of this. My recollection is that she was a poor surgical candidate, largely because of her medical comorbidities and the surgical challenges associated with this renal vein thrombus. I think it might actually even go higher than where that is growing or showing on this scan. And as I alluded to in my talk, this seems to be growing below the renal veins as well, portending a worse prognosis. I think we had discussions about if she could tolerate some systemic therapy up front. More and more, I feel like these conversations regarding surgery are about complementary surgery, not cytoreductive or not consolidated, but just complementary, figuring out when surgery can play a role. And a case like this, surgery would not necessarily be the right upfront treatment. So I think I passed it back to you in terms of systemic therapy.
Yes, you did. And and just for context too, we did completely stage her. So this was all locally advanced disease. So Dr. Appelman, what would you recommend? She has many comorbidities, but would you recommend systemic therapy?
I think you could try it. I think you could try it with great trepidation, and I guess it would depend on the exact comorbidities. Would she tolerate a TKI, to think of an IO-TKI combination? That if she would tolerate that, that's what I would start with.
Absolutely. Dr. Hernan, we actually did also talk to radiation oncology because they do, they have like MR LINAC and everything like that. So would you offer her also some focal SBRT?
Yeah, so she clearly has pain and she's symptomatic, so there is a palliative indication for sure, if nothing else. But she also does not have any metastatic disease, so this would be more cytoreduction as well as trying to get as much control as we can. So I would not just deliver a palliative dose, I will be more aggressive and using the adaptive and perhaps even MR LINAC. I would try to do 40 gray and even 50 gray perhaps within the tumor and do 1 treatment per month, just like the case that I did, and see how much local control we can do.
Absolutely. So interesting in this case, we had a really great discussion, I actually offered her lenvatinib and pembrolizumab. We offered her 40 gray MR-Linac radiation. We offered her surgery after all those two things as well. It would be very complicated, like Dr. Chang said. Vascular would have been involved. So we were all ready to go. We were all ready. And then with our team, with our pain control, she actually, after we presented all the possible treatments that we could do in order and how it would go, she having come down to Boston from Maine, she actually elected that is not what her wishes were. She wanted to have actually comfort care, and she decided to actually go home under hospice care in Maine. But this was a really well-informed decision, though, with herself and her family, and going over all the toxicities of everything that can happen. And we always said, you can come back if you ever change your mind. We're willing to offer you these therapies. But she made her decision, and we respected that. So that was So I don't know what her status is now, but that's she left the hospital, but she made the decision. But so at least in this case, we were going to do a little bit of lenvatinib pembrolizumab. We were going to bring in the radiation, and then or consolidate with surgery, depending on if she responded. But for this case, I was really trying to focus on starting her on some sort of systemic therapy. I did think she would be able to tolerate TKI, something where I would imagine in the beginning I would start at full dose, reduce really quickly. But again, it was more of a social situation and her, what was really going on. But I was glad that we could have those discussions together as a team with all of her doctors and her family and everything. So it was what she wanted, and we respect that, of course. Okay. So our take-home messages for this session, as we discussed, a multidisciplinary discussion is essential for these complex cases, and will provide patients different and effective treatment options for their kidney cancer. And it is something that, for all of our specialties, having discussions about each of these cases really does make a difference in patient care and what could be best for them and for, their quality of life as well. Now we're going to be able to take some questions. So if you have anything, please come up to the microphone so we can hear you. And any questions? Oh. Go ahead.
Viraj Master from Atlanta, Georgia. Really excellent talks, and I learned a lot. One thing I would say about the Budd-Chiari syndrome, yes, as surgeons we're often taught not to operate on patients with Budd-Chiari. However, for patients with IVC tumor thrombus who have Budd-Chiari, in my view, they don't have a bad liver that's causing the Budd-Chiari. They have something blocking the drain, meaning something in the cava. So at Emory, we have now, in the last few years, gone to a strategy of early cardiac bypass for patients with tumors that are bulky, obstructing the hepatic veins, causing Budd-Chiari. Because if you try to do everything from the abdomen, the liver is too stiff. But if you can relieve the obstruction starting from above with the cardiac surgeon, relieving the hepatic vein outflow obstruction, the patients can then go on and have their abdominal surgery done. So just a thought and something that we've been doing. Thank you.
So my question is to Dr. Hannan. Great session. So let's consider the last case, and would the patient be eligible for systemic therapy? Where do you see fit radiation therapy to the thrombus if the patient is eligible for systemic therapy?
So a great question. So, we all understand systemic therapy is essential because that is doing two things. One, it is also itself going to try to locally reduce the thrombus level and the tumor, but also these patients are very high risk. So they are more than 40%, 50% risk of systemic failure. So systemic therapy clearly has a role. I think your question is, can we do radiation concurrently with systemic therapy? Now, in terms of data-wise, IO together with radiation has been fairly safe concurrently. Now, with TKI, yes, we worry about GI toxicity. So my personal preference is to hold the TKI for 2 days before the radiation and then 2 days after the radiation, because TKI have a fairly short half-life. So that's my rationale, to hold it and then do the radiation. With this particular case, again, with using pulsar, we are seeing a lot less toxicity, not just because we are spacing out the radiation and allow the bowel mucosa to heal, but also because we are able to reduce the tumor and shrink the radiation field. So with those together, and then holding the TKI a day before and after, 2 days before and after, I think it will be fairly safe.
So you would go at the same time. You wouldn't start first systemic therapy, wait for the first CT assessment or MRI assessment, and then go for radiation therapy?
No, I would start them both together, and then, I would do them together and then do an assessment in 3 months. You could start systemic therapy first and then do a reassessment to see if there is evaluation, but in my understanding, radiation would be stronger and more effective in reducing or killing the tumor locally than systemic therapy would be.
Michael Stadler, Munich. One thing I want to add to this discussion is active surveillance. If you have the second patient or the first one you presented with this small renal mass, or you have a lot of medical conditions that are preventing you to do the surgery right away, why not watch that patient? Is it T1A, T1B? You can easily just follow them up and see if there is any dynamics in this tumor. And if it's not, then you don't eventually have to treat them. We have a tendency of throwing everything that we know on the patients, which we maybe not have to do all the times. Sometimes it's okay just to watch them and to say, hey, there's always something we can do. We can fix your aortic stenosis, and she might be a surgical candidate without any issues. Or do the radiation a little bit later. It's actually the same like Laurence is going to. We need to put everything that we have into the equation right now and treat the patient with everything that we have, or just give it a little bit of time. And I think 3 months of a run-in phase or even half a year is not too bad for those patients.
Yeah, no, I agree with you. The issue, though, is we worry about pulmonary embolism. We worry about thrombus, which has blood flowing through it all the time to shed more metastasis. So in my mind, the longer you delay, the higher probably the risk is for metastasis. But something that's entirely speculation, so we just need to probably see. But I agree that starting systemic therapy up front and delaying radiation may also be an option where you can see the response and act accordingly.
And just to address the first part of your question, I couldn't agree more. Not everybody needs to die with a scar. This patient had already been on surveillance for 2 years, and this was a fairly aggressively growing mass, and the family was not willing to continue to watch it grow once it passed 7 centimeters.
And just to add to that, I think that not necessarily the first case, but these are tumors that are identified during evaluation for various reasons. So often I find patients coming with multiple diagnoses at the same time, and certainly prioritizing them, particularly this 4 centimeter partially cystic mass, I think is totally reasonable for active surveillance. But I think the key that's been brought up is having the patient weigh in as well. I think sometimes when we sit back here and say, oh, this is something that we can clearly follow, but patients, because they had a neighbor who did that and they died, or they had, some other cognitive bias, it may not be as reasonable. So, but definitely active surveillance should be part of that conversation.
Yes?
Yeah, so Matt Campbell from MD Anderson. So the Budd-Chiari scenario is always a huge challenge, and I think there's very little literature to guide in what we do, and feel very fortunate to work with Jose Karam and others and our really strong IR radiation oncology team and discuss these with Chad Tang and others. From a systemic treatment standpoint, it's all anecdotal, but I think this is where lenvatinib and pembro can really shine because it's very clean in the liver. Most of these patients have very high LFTs. There's often a lot of trepidation, but this is, I think, where lenvatinib starting out at a full dose and just going for it to really cytoreduce can get patients through this in a very dangerous state where they're at imminent risk of death. So I think that's been our approach from a systemic treatment standpoint.
I agree. I think it's nice that the rate of primary progression with these combinations, IO-TKI combinations, is very low in the single digits.
Hi, Joe Panero from Temple University, Fox Chase Cancer Center. I just wanted to have a comment on case 1. I can probably speak for Grant as far as from an IR standpoint. That would be very treatable for ablation. We actually do anesthesia for less than 10% of our ablations. So microwave, it does hurt a little bit more, but cryo, it's not a problem at all. So Cryoablation for sure. The approach-wise, I probably wouldn't do microwave, given how I'd have to place the probes, but cryoablation would be a very doable option.
Thank you. Would you argue that cryo would have been better for this patient than the SBRT with no needles or risk of bleeding?
I'm a little biased. I mean, from a complete response standpoint, I'm going to get a better result, personally.
You believe the
With a
cryo?
lesion this size, so for me, if I'm doing one that's borderline T1B, which that looked like it could have been, I don't know if it was over 4 or not, I tend to do, actually in 2 stages, I'll do an embolization first. My bleeding rate goes down to 2 to 3%. Normally, you're going to be around 40 to 50%, not maybe clinically relevant, but it'll affect the ablation. So if I have a borderline T1B, I'll embolize day one, ablate day 2. And the results are great. And there was, I mean, it was exophytic. It wasn't really close to anything critical. I wouldn't have had any real concerns about injuries or complications or things like that. They can happen, obviously, but it wouldn't have been a concern.
Thank you. Do you want to respond to the complete response rate?
For radiation, we talked about the complete response rates on the order of 95 to 97%. This tumor was close to 4 centimeters, and the IR ablation, I think the local control rate starts to decline past 3 centimeters, but it sounds like it's still pretty good. So yes, these are all options. The other issue with this particular patient, as you mentioned, was not a very good anesthesia candidate also, so something else that needs to be taken into account.
So I have a couple of comments. So I think, Raki, when you mention complete response rate, you mean local control, right? Because we rarely see disappearance of the tumor completely. Is that correct?
I'm actually having trouble hearing you from that mic particularly.
When you say complete response, you mean local control, because we don't often see disappearance of the tumor completely with radiation.
Correct. So when I say, local control, I mean consolidation, I mean local control, right?
Okay. So this was a follow-up comment for Matt. So at UT Southwestern, we've started a trial with Len-Pembro, also given the high response rates compared to other IO-TKI regimens for patients with tumor thrombus. So we are eagerly waiting to see what that shows. But I think that's, given the 70% response rates in metastatic setting, if you are cytoreducing, that's probably what makes the most sense.
Jim, is that a neoadjuvant trial?
Yes, it's a pre-surgical trial.
What's the eligibility?
Tian, do you remember? So it's tumor thrombus, right? Yeah. All even level 1?
I have I made a slide for it, but there wasn't enough room, so I had to, it's in my backup slides, actually. We could try to find it.
Right. So maybe, it's low, I forget what is a cutoff of the thrombus, but it's patients with IBC tumor thrombus. And the goal is to reduce the tumor thrombus prior to the surgery. The PI is Vitaly Margulis.
Great. That's awesome. Thank you.
Any other questions?
I had a question for Dr. Chang and the other surgeons. In reading through the literature, both renal cell and other tumors, in the fine print of many papers, they mentioned a poor correlation between clinical response and histologic response with cytoreductive medical treatments, whether it's chemotherapy and other cancers, IO, TKI. What has your experience been when you've operated? Have the preoperative, post-treatment films been faithful to what you've seen in the OR? Have you been surprised by the pathology or intraoperative findings?
You're saying that the histology, does the histology associate with any surprises in the operating room?
Yeah, and versus the scan showing a radiographic response.
Yeah, I mean, the vast majority of our tumors are clear cell renal cell carcinoma. I tend to find that they come out pretty well. Some of the other diseases, some of the other variants are more infiltrative. I think it can be more challenging. So in general, and that's a very rough statement, in general, the clear cell might be a little bit easier to resect, less of a surprise, whereas I think I found some with some sarcomatoid variants or other variants that are just really stuck, and it's a real bear and potentially higher morbidity associated with it. But it's far from a really established relationship. I think some of those clear cells can be really challenging as well.
Well, in the absence of any other questions, thank you so much for attending session number 1. Please stay tuned for session number 2, entitled Intro, Resilience, Science, and Treatment Burden Background, which will begin in just a few minutes. Thank you.